We have ample time for questions, which is what we were hoping to do. Just to reiterate what we've heard about over the last hour and 15 minutes or so is we talked about optical imaging, MR perfusion and diffusion, CT perfusion and spectral imaging, PET-CT for surveillance, and ultra-high resolution MRI. So we're open for questions if anyone has any questions. Yes, ma'am. Could you come up? Oh, could you come up to the microphone? I'm sorry. I was going to repeat it, but no, you're fine. I think everybody else wants to hear.
Dr. Yu, you started out your talk by mentioning that there is a lack of evidence in surveillance for head and neck cancer, and so I would like to hear what you believe, because there is a lack of evidence of the clinical outcome depending on the intensity in the surveillance, the patient-related symptoms, clinical examination. Is there an additional value of imaging as in terms of survival?
Yeah, I think that, I mean, I didn't go into that in detail, but I think what I wanted to do was actually, when I did this research, this talk, there was actually one paper that actually flat out said that there was no benefit from imaging. I'm trying to remember where that paper was from, but actually their conclusion was that there was no use for imaging in follow-up with head and neck patients. And rather than sort of take that approach, that's why I showed that one example where the patient was clinically negative on their follow-up, and then there was all that tumor there. So I think there's no question that treating patients earlier with recurrent disease leads to better survival, better outcome. And I think my inference is that if imaging can sort of help, in that's that one case alone, show that we can pick up disease earlier, subclinical disease earlier, then I think the inference I was trying to say is that yes, it would. Did I find papers that actually look at that? I didn't go searching for that, because I think intuitively for me, as a radiologist, what I do every single day is I see that every single day. So I didn't go find a paper that sort of showed that.
But I do think that the question about is not necessarily directly related. In other words, finding earlier disease is not necessarily correlated to better survival, which I think is what she's saying.
Yes.
And that's been our finding too, is that I'm not sure that finding disease earlier necessarily does translate, and that's why it's so hard to find. And I think that's really what you're asking. And I'm really not aware of any data that shows a positive survival advantage. Most of them will show slightly most of them are underpowered, but they will show that there's no advantage. And the question is, you just don't have enough patients to know? But I think that's a really valid question. And at our institution, we generally don't scan repeatedly. We scan once as a baseline, as mentioned, and then scan for symptoms.
Just one comment too. It's if we go back and we actually look at PET 20 years, we've had PET now. The first papers actually came out in head and neck cancer in the mid-1990s. And I think part of what we've experienced as a society and organization is a fundamental rethinking of what PET does. When the initial papers were first published from Wake Forest and St. Louis, et cetera, what they said was the following. They did a series of PET studies, and they started performing PET during treatment, immediately after treatment. And the biggest concern at that time was not the ones, what were actually the negative PET scans. What Eugene eloquently showed was that if there's a negative PET-CT, then those eventually translate to no evidence of disease. But when those initial papers first came out, the way they were written, there was a statement made that if a PET-CT was done within 6 weeks to 3 months after completion of radiation therapy, there was a possibility of the radiation therapy potentially stunning the tumor, and it was a false negative study. So therefore, that was a foundation of getting more and more CTs to ensure there's no conversion. But in actuality, what time has shown was that if there's a negative PET-CT, 6 months, 9 months, et cetera, there's no need to do it. It seems like that threshold is getting even smaller, and Eugene showed some cases of up to 3 months if it was negative. Is that yeah. Other questions? Yes, sir.
I just have a question regarding the fluorescence technique. Do you biopsy say, a tumor beforehand and get a genomic thing to see if it has the receptor, in other words, not everyone's going to have an EG, right? You know what I'm getting at.
So I think the question is if they're EGFR negative, will they develop fluorescence? And very similar to the results of antibody delivery to tumors therapeutically, we're not finding a correlation between the fluorescence intensity and EGFR expression. And it is very likely our in vitro and in preclinical studies demonstrate that it is the turnover of the receptor probably and the incorporation of the cells that makes more of a difference for fluorescence intensity. So there are some tumors that express very low levels of EGFR that actually have very high fluorescence. And we're initiating clinical trials in those because their turnover is so high. So EGFR levels in a still shot picture are probably not representative.
Yes, sir. Can you just, yeah, go ahead. Thanks.
For suspected post-treatment recurrence, you spoke about MR diffusion as well as PET-CT. Which modality is better and which one do you suggest we use?
Between PET-CT and MR diffusion?
That's right. Is there any data to suggest that?
You know, the answer, and I think Eugene hit on this too, is a lot of it is what you're most comfortable with and what's available. I think right now, if I had to choose one, probably PET-CT. I think MR is a terrific technique, and I think in selected cases it works fabulously. So for instance, if I have an indeterminate lesion, we can go ahead and do the MR diffusion anyway at essentially no cost. It may cost us 1 or 2 or 3 minutes. But if the question is, if you had to bring a patient back, would I bring the patient back specifically for an MR diffusion or MR perfusion? My answer is no. If I had to bring a patient back for another modality, I probably would do a PET-CT. But these techniques can be done at the initial seeding of the patient, which is what we routinely do with very little time penalty.
Me too. I have a question for Dr. Yu. It is about MRI PET. What do you think? Is that a solution for something? Any role? Too early?
I think right now it's too early. I think we're just getting our PET in Toronto and our PET MR in Toronto. I think again we're in that real early embryonic stage. I think the paper is going to start coming out showing benefits here and there. It's going to be again the goal is to sort of get all of that together and see what we can make with it. And we're still not even there with PET-CT, so we're still beyond making generalizations.
I have a question for Dr. Moraldi. How much was your carbon ion?
Excuse me.
Did you have carbon ion in Brescia?
No.
Oh, I thought you said it was carbon
Pavia.
ion. Like, how much does that cost, and is your government paying for it?
The only one Italian center is in Pavia, and it is a center that's going to treat residual tumor, very small ones, like the adenoid cystic carcinoma. Some of the cases that I showed.
Okay, that's good. Can't wait till they flourish all over the United States. That'll be good. Other questions? We still have a couple more minutes. Yes, sir.
Vincent Grégoire from Belgium in Europe.
Hi, Vincent.
Nice to see you. You mentioned that according to your experience or to what you have seen, for diffusion-weighted MR, you propose to have a second during treatment around 35 grays. So during treatment, you propose to do re-examination around 35 grays. My question to you is that I guess you propose 35 grays, which is a good balance between false positivity and false negativity. But if you want to propose a therapeutic intervention after 35 grays, isn't it too late? In other words, if you want to increase the radiation dose or combine it with something else or whatever, isn't it too late? And 20 grays or 200 centigrays MR, wouldn't it be better in terms of possibility to propose therapeutic intervention according to what you have seen on your MR examination? What's your experience?
Well, thank you very much, and that really is the fundamental pivot because I don't know the answer. If you really tease out the data, and you look at CT perfusion and MR perfusion, and you look at the data and you see the differences in changes in blood flow and blood volume, there's a fair amount of heterogeneity in the response. And if you read the literature, it can drive you crazy. Finally, we went back and we looked at the time interval in which those were performed. And it really varied. We saw the reduction in blood flow and blood volume indicative of non-responders once those studies were done later in treatment, whereas the MR perfusion changes that have been reported if it was closer. The reason why I mentioned 30 or 3,500, and I don't have the answer, but at least we can start the conversation, is that there's some recent data coming out from WashU looking at cervical cancer. So, and their time points are somewhere between 3,000 and 3,500. I would pose the question back, is if we're treating patients with non-surgical organ preservation therapy, where do the radiation oncologists and the medical oncologists feel that they have given enough therapeutic dose where we could potentially introduce that fundamental pivot? And 3,500 is not dogma, but at least from the people that I've interacted, Avi, for instance, and others where he trained at WashU had suggested that level, but it may be closer. But my biggest concern is that if we do it too soon, the imaging that we're seeing is just the imaging of acute therapeutic response.
Well, because you are looking at the same tumor after treatment, but the problem is, I think that also it is not possible to elastically move the original voxel and understand what is now the same part of the tumor, how it is its signal. This is one of the drawbacks of this analysis. My question is isn't it the best solution to analyze the tumor before treatment? I mean, heterogeneity, I think, it is one of the focuses we have to analyze, the points we have to analyze. What do you think about it?
We've thought about, the challenge is that whatever imaging you need, the biological imaging techniques, you just have to make sure that if you perform your survival analysis, your Kaplan-Meier plots, et cetera, that the findings that you're identifying on pre-treatment imaging are actually supersede staging. And that staging has to be AJCC, UICC. So I agree with you, yes, pre-treatment is good, but is there an incremental benefit in the findings that you get on these biological imaging techniques versus regular staging? I just haven't seen that separation. And sometimes I think these techniques just may be another way of identifying stages. For instance, very, very high SUV uptake just may be indicative of a larger stage tumor. Maybe we have time for one last question. Anybody? If not, I want to thank all of you for coming, my panelists for a very interesting and exciting session. Thank everyone for their input. Thank you very much.